Hi, Dr. Mouchantat. It's great to be with you tonight. I'm looking forward to having a conversation with you about long-term care and post-op considerations for breast reconstruction patients. So just as a quick introduction for our audience, my name is Ashley Libby Diaz. I am a board member of Brave Coalition Foundation. I am a breast cancer survivor, and Dr. Mouchantat is my plastic surgeon and did two-stage surgery for me about 8 years ago, which is just astounding. So super lucky to have Dr. Mouchantat as my surgeon, and also to have him on our medical advisory board for Brave. So thanks for being with me. Would you do us a favor, please, and just say a little bit about yourself and your practice?
Thank you. Thank you for the opportunity to be here. Glad to help. I am plastic surgeon in Denver, Colorado. I'm in private practice. Most of the reconstructive surgery I do is breast cancer based. About 90% or more of what I do with this reconstruction is breast cancer related. I've been doing that for 26 years now. It's always been, part of my interest in medicine in general and in plastic surgery specifically. I have several breast cancer surgeons I work with and do mostly implant-based and some latissimus flap-based reconstruction in 3 community hospitals in the metro area.
Excellent. Thank you for being here, and thanks for what you do for all of us. So we went on quite a journey together when I had my reconstruction close to 8 years ago. And there was a lot that we talked about and considered in my post-op recovery. And I'm sure this is a big area for a lot of surgeons and their patients to make sure that breast reconstruction patients are getting the best outcomes. So would love to hear from you. What does post-op care look like for breast reconstruction patients in your practice?
Well, most of us want to control pretty much everything. We want to control your activity level, how much you move your arms, what you eat, when you shower, and how much you're moving. So initially, the recent change, the most recent change is almost everybody, 95% of patients are done as an outpatient, even bilateral mastectomies with immediate reconstruction. So most people go home. The big benefit of going home is people move around a lot better. It's very important to keep people moving to prevent clots in the veins, because all breast cancer patients are at high risk for getting clots in the veins around the time of surgery. So I have people walking for 5 minutes just around the house, out to the mailbox, wherever they feel up to going, for 5 minutes every hour that they're awake for about 2 weeks after surgery. At that point, they can sort of normalize their walking if they want to walk the dog or walk around the block or take a walk with a friend in the park or something like that. It is not as important after that amount of time, how long they're up. In the old days, we used to keep people out of the shower while they were recovering, but now we realize that wounds are healing rapidly on the inside, and then we can seal the wound with the tissue glues. Even though people are sutured together for strength, the tissue glue makes people waterproof. So we're generally getting people in the shower in 48 hours. I tell everybody they can shower at 48 hours and they can wash their own hair. And the reason I tell them they can wash their own hair is because we don't want people's shoulders getting stiff after we operate on the front of the chest. Of course, it's sore, so people tend to splint, their shoulders move forward, they move down, the arms stay close to the body, and then get very stiff. So to minimize what we need to do for physical therapy after you're well healed, say after about 6 weeks, I tell people take a shower, wash your hair with good posture. So get your arms at least this far. And what we found is by getting people's elbows as high as just about the shoulder level or a little above, in that first few days. Rarely do they get very stiff and need a lot of physical therapy. Although physical, I don't mean that we avoid physical therapy because it's a bad thing. It's a great thing. Helps make people more comfortable, gets their range of motion, gets their strength, teaches people what to watch out for in the future. So that's also part of it. But that comes later at around week 6. The other recent change is there's some non-scientific trend towards improving outcomes in patients who take a nutritional supplement that replaces some of the nutrients that we use when we're stressed. It's just a simple packet of a nutritional supplement. It's low calorie, but it has some amino acids and some immune modulators in there that we use more of when we're stressed. So we precondition people with about a week of using that twice a day and 2 weeks after to help support the body's response to the trauma of surgery nutritionally. Now, when we have people getting back home, so they can eat whatever they feel like eating, but we do remind them that, pie and ice cream is not the best way to recover. So,
yummy as it might be.
Really, we want you eating, yeah, although even though it's good, it's good for the spirit. It's good to think about good, solid nutrition whenever you're eating in the recovery period. And of course, people don't feel like it so much. So we recommend eating more often, smaller meals, whatever it takes, but to think about getting a little more protein than you normally would. Because our bodies are going to use about 50% more protein than our baseline to heal those wounds. Even though the skin incisions can be very small, can be down on the fold of the breast and very well hidden long-term, there's a lot of surface area that's healing. And so you need good nutrition to make strong scars. And we don't want that process to be delayed by anything like a nutritional factor missing. So there's activity, showers, what we have people eating, and then the big hard part, now that we've done better controlling people's discomfort with non-opiate pain relievers by blocking nerves before we start. We have people off pain medicine much faster, taking things like Tylenol, sometimes anti-inflammatory type pain medicines. We have people sort of getting back to feeling good, but we need to let those wounds heal. We need to let the fluid stop leaking out of the tissues and get all the healing points inside to seal up so we can get your drains out. And that usually takes 2 to 3 weeks, often. So in order to do that, we do limit the activity level. We keep the heart rate low. We keep the arm range of motion limited to just the top of the head. Nothing that requires a lot of strength. So 10 pounds maybe for lifting. Recommend you don't drive for a couple of weeks because there's a lot of arm motion with steering a car. We're not really aware of that because it's such an automatic thing, but we want to sort of optimize everything we can control to get wounds healed quickly without any issues. So we're keeping people fairly well restricted during that time. Drains come out. We then start compression so that swelling won't restart after the drains come out for about 2 weeks. And after that 2 weeks is when we can really push the range of motion and start allowing people to use a little bit of effort in their activities. So that's usually around week 5 or 6. Physical therapy if necessary, normal exercise gradually. I tell people to start ridiculously light if they are weightlifters or runners or going to get on their Peloton and push as hard as possible. I don't recommend anybody get on their mountain bike immediately. I say pedal for a few days on the flats and make sure it's okay before you go do anything too much fun. But then after week 6, we let people sort of gradually go back to normal. And most people do. I mean, I have a picture of a patient jumping a motorcycle after her recovery.
Wow.
I was pretty impressed.
That's really impressive.
So that kind of wraps up early recovery. We control nutrition, activity level. We do not want people sedentary because it's dangerous from the standpoint of clots. People don't breathe deep when we do that. the innovations in pain control. There's an acronym ERAS. It's sort of a way of sort of enhancing people's activity through keeping them active, feeding them, getting them up, getting them moving, and getting them off opiate pain medicine. And it really works. We have people now using very little pain medicine in that post-op time. Once people get to be active, we often have some tinkering surgeries to do, but usually those per second or third or whatever kind of procedures are necessary from that point on have lighter recovery periods. But during that time, we do want people to work on their fitness. One of the things that we, with breast cancer specifically, is you can decrease your recurrence risk by dropping your BMI down into the ideal range. And that's not how most people are going to live, or where most people or many people are going to live, but every little bit helps. So we encourage people to start getting back into a routine where it's part of their routine is no longer just nose to the grindstone, working and serving a family or whatever else they have, but to do some self-care. And that means time off for exercise and all the other activities that it takes for peace of mind. What we really want to see is people going back to 100% of everything they want to do. So hobbies, sports, exercise, family life, intimacy, we want it all to be as normal as possible. And then I leave people alone for a while. The current recommendations for long-term follow-up, especially for implant reconstruction, is we start looking for any problems with the implants at around year 5 or 6. And then the FDA recommends screening for the implant issues about every 3 years thereafter. They left out a little bit of wiggle room so you could have some leeway. I personally follow textured implants. So those are the shaped implants and sometimes round implants that have a textured surface. I follow those on a yearly basis because they are at a little bit of a risk for developing a cancer in the scar tissue. It's exceptionally rare, but I think if we follow them yearly, then we'll find anything before it becomes a significant problem. So I'll screen textured implants on a yearly basis, and then the first big screening for smooth implants is at year 5, and then about every 3 years thereafter. And that's a pretty easy office visit, physical exam, and an office-based ultrasound. The latest ultrasounds plug into an iPhone, and so your phone becomes the screen, and you have an ultrasound in your office. The cost is no longer prohibitive to do it. And we can see the scar tissue around the implant, whether there's any fluid around the implant, any lumps or bumps, and also the condition of the implant. So it's a very nice, easy screening tool. We don't have to send you off to radiology departments to get official screening or MRIs anymore because those devices have become so good. So long-term implant screening, starting at year 5, every few years thereafter. Textured implants I screen on a yearly basis. I guess the last big question is, what about longevity? How long do these reconstructions last? The answer is a long time. Now, you see, yeah, they do. Implant failure, the data given to patients at the time of surgery nowadays, with the new implant checklist that the FDA asks the manufacturers to make available and that we're supposed to give before we dispense implants, give worst case scenarios of longevity of implants. But what we see in practice is somewhere around a 10% failure of implants at about year 10. That is stacked into the second half of the 10-year period. At 4 years, it's usually less than 1% risk. So it does sort of creep up. Second 10 years, it's all extrapolated data, so we don't really know the answer there. But even if you assume the worst case, maybe it doubles in that second 10 years. So we still could have about 70% of implants intact at 20 years.
Wow.
Qualitatively, long-term studies are unusual that answer this question. Although there was a recent publication, I believe it looked at 12-year follow-up, or their mean long-term follow-up was about 12 years. and found very good longevity to implant-based reconstruction. Qualitatively still looking good, still comfortable, and people still satisfied. So I think long-term, we don't have to reoperate on a lot of people. There's sort of an internet myth or a rumor myth that says every 10 years you have to change implants. It's really not true. If you look good, you feel good, and your ultrasound is okay, you get to keep going without any interruptions in life.
That's amazing.
Yeah.
Thank goodness for that, right?
Right. Yeah. After 20 years, I'd have only redos to do at this point. I wouldn't be able to provide much service to all the new patients if things were breaking down that bad. It's not like I don't see revisions from, patients from a couple decades ago, but it's a small percentage of those people who need anything. So that's sort of the peace of mind, because we ask people to go through a lot at first. First, they're bombarded by cancer. Then they figure out they're going to lose their breasts. Then there's everything wrapped up in that. What's my life going to be like? How am I going to feel? What am I going to look like when I go out in public? What am I going to look like when I look in the mirror? What am I going to look like to my significant other? What are my kids going to think? All those things are wrapped up into it. And then we say, okay, make a choice right now what you want to do. So we do recognize we put you through a lot, but it's our job to make sure you just don't make any bad decisions. And people usually make good decisions for their future. And I think it works out well in the long run.